Hello, I'm Dr. Jay Reish, the EMS Medical Director for the Kansas City Fire Department. I wanted to take a moment and speak to you today about our department's Ebola preparedness. What you need to know about Ebola is that it's not as scary as we have been led to believe. Ebola is not a very hardy virus. It's something that can be easily killed with simple cleaning agents, antibacterials, and a weak bleach solution. First, I wanted to talk to you about the Ebola virus itself. Ebola is a filovirus similar to a family of viruses, almost like the flu virus. It's actually not a very hardy virus, and it's easily killed by everyday antibacterial and antiviral wipes, as well as weak bleach solutions. So why do we worry about it? Well, as you may have heard in the media, Ebola is a deadly virus. There is, once infected, a higher mortality rate. Over in Africa, it ranges about 70 to 90%. However, if you've been watching here, every single patient, with the exception of the very first patient, has recovered, and they suspect our recovery rate would be closer to 80 or 90%. Ebola, unlike the flu virus, is actually very hard to catch. While you might be in a room with someone or a group of people and easily catch the flu or any other cold, that's not going to happen with Ebola. To catch Ebola, one must be in direct contact with contaminated bodily fluids, such as saliva, blood, sweat, etc. The department has undertaken a number of steps to help ensure that our responders, yourselves, and your families, and your patients that we all take care of, are safe from the transmission of Ebola should you encounter a patient with the actual virus. But I want to say one thing. As of today, your chance of getting Ebola is as low as almost absolute zero, because there have been absolutely no cases of Ebola in Kansas City. Additionally, there are currently only one case of known Ebola in the United States, and that is that physician in New York City right now. So your chance and your risk of getting Ebola is very, very minimal. The chance that you will encounter a patient with Ebola is very, very minimal. But the steps that we have undertaken to help prepare you for your response, to prepare your training for your response, and the procedures related to that have been carefully thought out based on the recommendations of the CDC, local health departments, and the IAFF. Putting these together, we have developed a comprehensive set of policies and procedures for you to follow, and a very thought out response plan to help minimize any potential risk. The number one thing you need to do first is read and understand the directive for responses put out by the chief of the department, as well as the EMS Medical Director's memo, the memo that I put out, that provides you information about what Ebola is, what some of the signs and symptoms of Ebola are, and the steps that you need to take to protect yourself. While I'm not going to review each and every detail about our preparedness plan, because that could change as new information becomes available, I do want to review a few things. As I said before, Ebola is a hard virus to catch. As such, you need to have contact with contaminated bodily fluids that not only touch you, but need to get inside your body through contact with a mucous membrane or an open wound. Therefore, the procedures we have laid out help protect you from getting that sort of exposure. All ambulance qualified personnel will be receiving training on the appropriate PPE to wear initially. After that is completed, then all additional suppression personnel will also be trained on the appropriate PPE to use if you should encounter an Ebola type patient or any patient requiring that level of personal protection. As recommendations for a PPE change, we will update our procedures and our protocols to make sure that you have received the best information and our plan is the most up-to-date based on the recommendations put out by various sources. That being said, the number one thing you can do to protect yourself from getting exposed to an Ebola patient or to Ebola is to slow down. That's number one. We don't need to be rushing in like we normally typically do in these type of scenarios. For a majority of cases, we will know ahead of time or suspect ahead of time based on our EMD process and our screening process that you are responding to a potential Ebola patient. As such, we will be notifying you to slow down your response and actually stage and wait for additional personnel with additional equipment. So you won't be, quote unquote, rushing in without having some foreknowledge. Secondly, should you find yourself with a patient that you suspect having Ebola, you'll be instructed to back out to a safe distance, put on your PPE, and call for additional resources. One suggestion, should you be entering a scene where you suspect the patient may have Ebola, would be to start your initial questioning from a distance of 7 feet. At that distance, you are protected from any potential droplets or liquid contamination from the patient and are at very minimal risk, even if you're not wearing PPE. Again, remember, Ebola is very hard to contract and you need to actually have contact with bodily fluids. So if you're in a scenario where the patient appears stable and you're able to start your questioning from a distance of approximately 7 feet away, you can do so to ask the screening questions that you'll be instructed later on. So once again, I do want to remind you one other thing, that it's always appropriate to use the appropriate PPE on all our patients. As we start entering into flu season, you'll be encountering patients who are coughing, sneezing, etc. And it behooves you to actually wear personal protective equipment at that point in time, such as an N95 mask for yourself and a simple face mask for the patient. You're more likely to contract flu or a simple cold than you are ever likely to contract Ebola. So remember to protect yourself, your colleagues, and your family by wearing your appropriate PPE all the time when you encounter any patient where you could get exposed to their bodily fluids. Remember, remain safe, remain calm, go slow, and keep your head about you, and you'll be able to handle any potential case of Ebola or any other infectious disease using the policies and procedures that we have laid out for you, and we will continue to update you as necessary. Thank you very much, and have a nice day.
Welcome to the presentation on the operational directive for the Ebola virus disease. I'm Division Chief Michael Latta. First, let's start with a little background information on what the Ebola virus is. It's a viral hemorrhagic fever. It's been around for a number of years. The nature is severe and often it is fatal. It poses a limited risk here in the United States, and we've seen the spread in West Africa because of the lack of the healthcare system there and the lack of proper personal protective equipment. Ebola is not spread through air. It's not spread through food or water. Currently, the information out of Africa is that no one has come down with the virus having contacted a surface. It's all been direct contact with blood or bodily fluid of a patient that has Ebola. So please keep that in mind. We want to avoid as much of the direct contact with the blood and bodily fluid as we can. We also want to limit our exposure to like needles in the back of an ambulance, so we're not worried about a needle stick injury. Incubation period, should someone be exposed to the virus, is 2 to 21 days, with 8 to 10 being the optimal time frame that's worried about. A patient having Ebola is not contagious until they start showing symptoms. As you can see by the map, there's a region in West Africa that is where the outbreak started and continues to be. It also shows the number of patients over the next few slides that talks briefly about the numbers that we've seen who's come down with Ebola and the deaths that have occurred. You can see that very, very few have occurred outside of West Africa, and currently in the United States, we only know of 4 patients and 1, the patient 0 from Dallas, that actually died of the virus. The symptoms, and the number 1 symptom obviously is fever. Currently, the CDC recommendation is 100.4 degrees Fahrenheit. So if we can take the patient's temperature, rule out a fever, that helps in our diagnosis of the virus. The next slide will show you signs and symptoms covering from vomiting, diarrhea, fever, again, muscle ache, cough. All of these are flu-like symptoms. We're coming up on flu season, so we're going to see a lot of patients with those generalized symptoms. So it's important then, if we recognize someone with the flu-like symptoms, that we look at, have they traveled? Have they traveled to West Africa areas? And as you see by the slide, it lists Guinea, Liberia, Nigeria, Senegal, and Sierra Leone as some of the number 1 areas where the virus is currently being seen. We want to make sure that, have they traveled within the last month to any of these areas? If they've not, have they been in contact with someone who has traveled in the last month to one of those areas and returned to the United States? So what we want to do then is, if they've traveled, or someone they've been in contact with has traveled to West Africa, and they have these flu-like symptoms, we want to start by taking our universal precautions. The CDC, or Center for Disease Control, lists those as standard, contact, and droplet precautions. And we'll go over each of those as we move forward. If we suspect that this patient could possibly have the Ebola virus and it was not picked up on dispatch, this is our time to slow down, delay our close treatment with that patient, and make sure we're calling in the additional resources we need. As we talk about the different types of precautions, the first one is a standard precaution. This talks about blood and bodily fluids and any secretions that we need to try and avoid. At this point, if the patient has any open sores or wounds, again, those are potential areas for exposure to any infectious disease, and we should be taking precautions. Gloves, if necessary, a gown, or even Tyvek or even our Tychem suits. Next is droplet precautions. Mostly this is around infectious diseases that are airborne. We want to make sure that we limit our exposure to anything that might get airborne. We're going to put on a mask. Most importantly, we're also going to include our patient in that. Can we get a surgical mask on that patient? Again, if they're spraying because they're coughing, sneezing, or we have to do something that's an aerosolization, like a breathing treatment, we want to make sure we've taken extra precaution, not only with the face mask, but perhaps with an eye protection, as well as maybe even a face shield, and then preventing it from getting on the rest of our body by a gown or a coverall of some type. The last is contact precaution. And here again, it's just saying that we need to limit our contact with any of these patients' blood or bodily fluids. If we've taken those 3 steps and avoided the contact and making sure that we doff anything that we have put on to protect ourselves correctly, we will have succeeded in avoiding an exposure to any infectious disease. Dr. Reish has stated that EMS providers coming into close contact with a patient that is suspected of having Ebola needs to wear the following personal protective equipment. They recommend double gloving. They also recommend at this point a Tychem coverall suit, and we're even going to provide rubber boots that will go on over those coveralls. They not only recommend an eye protection of some kind of safety glasses, but also a full face shield. We also recommend an N95 mask for our personnel. The CDC recommends that no body parts or no skin exposure from us going in to see a patient. Additionally, what we have to consider is if this patient has copious amounts of blood or bodily fluid, they're actively vomiting, sometimes with Ebola, it's projectile vomiting, diarrhea, and at end stages, we're going to see a lot of blood with this as well. We want to take extra precaution. How do we do that? Well, we can place the patient in a Tyvek suit. We can make sure the patient is wearing a mask. We also have a plastic cover that we can slip over the stretcher and put the patient on the stretcher and wrap that covering around the patient. Again, just preventing as much of that exposure as we possibly can. The next slide looks at our risk. And again, it's important to notice what is our high risk procedures. Number one on there is needle stick. Dr. Reish has talked about limiting our care for these patients to BLS care as much as possible. Provide supportive care and avoid any aerosolization, breathing treatments if we can, IVs or needles in the back of the ambulance once we load this patient and are ready to transport, and then any other high-risk procedure, maybe like an intubation. If we do this, again, we are limiting our risk. We want to cover ourselves in our proper PPE and cover the patient as well. This will help us exposure. If we walk into a room and a patient now has signs and symptoms, flu-like, that are similar to Ebola and meet the travel requirement, we're not in PPE at this point. We've not been really exposed as long as we have a standoff distance of about 7 feet, and that's what's recommended. So just keep that in mind. Any other is very low risk exposure for us. And this is a good time to make the point that currently in our area, we have seen no patients with the Ebola virus disease, and so our possibility of getting it is almost nothing. The next one starts into the directive, which is why I was brought in to talk to you. And again, the directive starts with, what if we get to the scene and we've had no notice that this patient may have it? It's recommended that if we get flu-like symptoms, we stop, we slow down, don't quickly approach a patient. Have a standoff distance of about 7 feet. Ask the travel questions. Have they been to West Africa within the last month? Have they been around anyone that's been to West Africa in the last month? Keep these in mind as we move forward. Then we start talking about our PPE and what's needed to protect us. And as you go down and we look, we've already talked about the Tychem suits. We've already talked about face shields. We don't carry this equipment on an ambulance. Now's the time that we notify the communication center we have a potential patient and we need assistance. The terminology that we would like to use in notifying the communication center is we have a sick patient requiring universal precautions. The communication center has reviewed this directive and will know additional resources need to be sent. It's our time to back away from the patient, put a mask on ourselves, potentially a mask on the patient as well. Consider, are there blood and bodily fluids present in the room already? And if so, maybe we actually need to back out of that situation until we properly get our PPE available to us, and obviously calling for assistance to get the equipment and the PPE available to us. As you look, it starts with the triage, and at this time it'll blend in from the we didn't know this patient, and the center has triaged that this patient potentially has the Ebola virus. They will tell us at that time through the pre-arrival instructions that our units need to stage. At that time, we're going to slow down, we're going to stage, we'll wait for the battalion chief and the assistant division chief to arrive on the scene with the proper PPE so that we can move forward with evaluating this patient. Obviously, an ambulance has already been sent to the call or will be sent to the call, as well as a BLS resource. If we determine in the setting that this is potential Ebola virus, we will ask that a field ADC as well as a battalion chief be sent to the call. At this time, we're going to request hazmat and the hazmat chief that will be sent. We're also going to have a pre-draped ambulance at Eastwood that can be sent as well, and that will be arranged as well. Units, again, need to stage until everyone is on the scene and we're ready to suit up and go evaluate the patient. Once the battalion chief or the ADC arrives on the scene, we can gather any additional information about this patient. If they've traveled, and we know this already, they also have flu-like symptoms. Now it's time to don our PPE and approach the patient. The hazmat team will be on the scene to make sure that we properly don our equipment and we're ready to go evaluate the patient. Hazmat will also be bringing thermometers that we can evaluate the patient's temperature when we make contact with them. We're going to approach the patient with our proper PPE. We're going to again evaluate for symptoms that are similar to the flu. Do they have a fever of 100.4 or greater? Do they have a cough? Do they have maybe a headache? These generalized symptoms. Have they vomited? Do they have diarrhea? Are they potentially an Ebola patient? We're again going to ask, have they traveled within the last 30 days to the West Africa area, or have they been in contact with someone that has traveled to those areas? If we verify that all this is correct, we still assume that this patient has the Ebola virus. It is now time to get ready to transport this patient. At that point, we've got to make sure that everyone is ready and the receiving hospital is now ready to accept this patient. The communications center should have already notified the shift deputy to make sure that they're aware of the situation. Safety officer, Assistant Division Chief Bill Gulick should have also been notified, along with our medical director, Dr. Reish. They will also notify the health department through their pager system so that we can make sure everyone is aware that we have a potential patient. The on-scene incident commander or the medical group supervisor will make sure that the hospital is contacted, preferably by phone, so that we can have a conversation with them to get ready to receive this isolation patient. Our words to them are, the patient needs an immediate isolation bed. When we tell the hospital this, they're going to know that we are coming in with this potential patient and to be ready when we arrive at the hospital. At that point, we're going to have the ambulance that is already pre-draped, or drape an ambulance on the scene if necessary. We're going to have to assign someone outside the hot zone, someone to drive the ambulance. Once it's sealed off, the person driving does not have to be in PPE. And again, what equipment do we need to care for the patient in the back of the ambulance once the patient has been loaded into the ambulance? We'll also notify the hospital what our ETA is of this patient. Once we arrive at the hospital, we're going to offload our patient and met by hospital staff and take them to wherever their isolation room is at that facility. Once we have transferred care of our patient to the hospital staff, it is now time to get our stretcher back to our ambulance, close the ambulance back up, and then prepare for the doffing of our PPE. Hazmat is going to meet us at the hospital to help us doff appropriately our PPE. A critical point, as the two nurses in Dallas that have came down with the Ebola virus, they believe were both exposed in doffing their PPE. That's why we want the experts to help us in this critical time. After the call, we've now doffed our exposed PPE. We're ready to return to Eastwood. The ambulance is closed off in the back. The crew will appropriately drive the ambulance back to Eastwood, where the MST department will take over the ambulance. At this point, they will handle, through their procedures, cleaning and evaluating that ambulance. So that will be taken care of. The last key we need to make is if this patient is not transported and we believe they had the signs and symptoms of the Ebola virus, we need to make sure that we have communicated well that we are not transporting the patient. Either the patient refuses to go to the hospital or was in a cardiac arrest and was left at the scene. We need to make sure that Assistant Division Chief Bill Gulick, the health department, and the medical director are all aware that this patient was left at the scene and not transported. If Dr. Reish or Bill is on the scene, they will make sure those notifications happen. Again, I would like to make sure that at this point you review the summary. Please take time to look at the desktop and review this directive from Chief Berardi. It contains the information that we presented in the step-by-step process that we want followed for these suspected calls. Also, Dr. Reish has sent out an updated medical guidance for how to handle a patient with the suspected Ebola virus. So please take the time to do that. Reach out, ask questions if you have them, and we will be here to help you through this. Thank you.
We've talked about the good and bad information that's out there, and that information is changing rapidly. So we've asked Dr. Alan Morrison, an infectious disease doctor, and a hospital epidemiologist, who is also a consultant for Fairfax County Fire and Rescue, to speak with us. And interestingly, he was directly involved with the Ebola arresting event in 1989. Dr. Morrison, thank you for being here. Let's start out by give us a little history on the Ebola virus.
Ebola virus was named after the Ebola River in Zaire and was first identified in 1976. During that initial outbreak, there were over 200 individuals who were infected, with over a 50% mortality rate. Thereafter, the following year, over 300 people became infected with an 80+% mortality. Additionally, one small outbreak in the continental United States occurred in Reston, Virginia, in a primate facility where several people seroconverted, but there were no fatalities. It was felt at that time that the Ebola Reston strain was less virulent for humans compared to Ebola Zaire. Finally, there was a single case of an ethologist who was doing a necropsy, an autopsy, on a dead chimpanzee, and that case occurred in the Côte d'Ivoire. So now we have a current outbreak that's been described, and the details of that are coming in piece by piece. The current distribution of Ebola has been seen in Africa, Western Africa, predominantly 3 countries. In an important paper just published in the New England Journal of Medicine this week, the current data suggests that as of the middle of September of this year, approximately 4,500 cases, including those that are probable and those that are definite, have been identified. The case fatality rate is in excess of 70%. The incubation period, which is no different than Ebola viral disease cases in the past, has been tacked at approximately 11.5 days. In fact, calculating local doubling times in Africa and putting into effect what we do know about transmission and modes of transmission, unfortunately, the estimate is that by the first week of November of this year, there may be 20,000 cases of human Ebola disease in Africa.
That's interesting facts. You talk about the mortality rate. We've received a number of questions and comments regarding the number of influenza deaths that occur across the country every year. How does this Ebola virus compare to influenza? Put it in context for us.
Influenza virus, highly contagious, airborne spread, obviously very different in that we have a very effective vaccine strategy, does result in several 100,000 admissions per year to U.S. hospitals. The death rate certainly is plentiful. Airborne diseases such as influenza, tuberculosis, SARS, with which we have familiarity with an outbreak, and even Neisseria meningitidis, the classic meningococcal infection, as airborne spread viruses and bacteria, the infectivity would be viewed as very high. To date, the caseload with Ebola virus is very low, but the mortality rate is exceedingly high. However, there does not appear to be any incidence or event that suggests a change in the transmissibility of Ebola virus. In other words, contact spread only, and there does not appear to be any evidence for airborne transmission.
So the key takeaway here is a much higher mortality rate in spite of the different mode of transmission. Let me ask you this. If we transport a patient that's suspected to have the Ebola virus, what is the testing process for that patient, and how soon would our member who transported this patient know if that patient was in fact infected with the Ebola virus?
As with any occupational exposure, whether it be HIV, hepatitis B, hepatitis C, as an example, the ability to identify rapidly the source patient as either positive or negative is a crucial element of the algorithm. At this point, there are very limited laboratory facilities who are able to perform acute testing on a potential source patient. Although those laboratory facilities do exist, the experience of our colleagues in Atlanta recently, and portrayed by Dr. Ribner and his colleagues, have led us to understand some of the operational issues that are attendant to this. What I mean by that is simple. For instance, having a laboratory contractor that will take a specimen to a facility where testing can be done seems very straightforward. In Atlanta, however, they discovered that their contractors, the courier services, refused to take and transport this blood specimen. That would be a hindrance. Therefore, the reliability of prompt diagnosis has some italics associated with it at this time. I'm confident that those things can be worked out, but at this point, there are some bumps in the road, and the ability to rapidly secure a diagnosis may be hindered by factors that we don't normally see in other occupational exposure events.
Which is why we see the long quarantine or isolation period that happens when there is a suspected exposure.
That's part of it. The 21-day isolation period is done partly to get information, but with an approximately 11.5-day incubation cycle inherent with this virus, you want to go at least 2 incubation cycles, approximately 21 days, to make sure that infection doesn't exist by virtue of symptoms emerging slightly beyond the known incubation period. So yes, there's a practical feature to this and a biologic feature that leads to that quarantining cycle.
So what does this mean for protection for our members?
We know inherently that emergency response is a high-risk activity. Everybody looking at this information understands that fully. You're in an uncontrolled circumstance where you have very little knowledge and you need to be maximally protected. The mortality with this virus in human disease is extraordinary relative to most things with which we deal on a regular basis. The updated guidance from the Centers for Disease Control this month, October of 2014, have outlined additional measures commensurate with the information that we have as follows. First, a face shield would be important, not because of airborne spread concerns, but because the end stage and active infection with this virus often leads, with patients presenting, with aggressive projectile vomiting, copious diarrhea. And this is blood-laden, and the reason is the mechanism of the virus infection. People die in disseminated intravascular coagulopathy. They bleed out of all orifices in a very ugly way. The opportunity to come into contact with direct blood from, for instance, projectile vomiting is a reason for the shield. Goggles alone, or goggles and a mask, do not protect skin. Specifically, the updated CDC guidance says, no exposed skin. So a face shield with a high garb up to the neck area. Recommendations currently including double gloves and potentially even taping the double gloves at the interface of the sleeve, the long sleeve, in case the glove or the sleeve would ride up or ride down respectively. So significant coverage of all exposed skin areas with a face shield that affords protection against direct exposure to skin. We must remember this is a contact spread virus, but the clinical features of the virus when infecting a person can act a little bit differently than a lot of contact spread.
As you know, the information that's being disseminated out there is changing daily. Thank you for joining us and sharing this critical information with our members.
It's a pleasure.